everyone. Thank you for joining for another session of Cancer Talk with Dignite. As you all know, Cancer Talk with Dignite are session planned with cancer experts to be able to provide useful and critical information for all newly diagnosed cancer patients and also their caregivers. Today, we have Dr. Indu Bansal joining us for the session. To give you a brief introduction about Dr. Indu, she is the head of the Department of Radiation Oncology at Narayana Super Specialty Hospital, Gurgaon. In today's session, we are going to talk about the basics of esophageal cancer and the treatment modality, which is chemoradiation therapy. With that, I'd like to welcome you, ma'am, for the session. Thank you so much for taking time off and joining us.
Thank you so much for having me here.
Thank you. Okay, so let's go on. Let's start off kickstart the interview. So before we go to the treatment modalities, the first question is around the basics around what causes esophageal cancer. What are the risk factors associated with this type of cancer?
Okay, so I think that's a very basic question. And esophageal cancer means cancer of the food pipe. First, we must understand what is esophagus. So, it is a cancer of the food pipe. So, it starts from just below inside the mouth, and then the food pipe joins the stomach. So, the cancer arising anywhere in this path in the food pipe is known as esophageal cancer.
Yeah.
So the most common cause of esophageal cancer is tobacco consumption in any form. मतलब बीड़ी, सिगरेट, पान, तंबाकू, हुक्का अगर आप किसी भी फॉर्म में लेते हैं तो आपका फूड पाइप के कैंसर का रिस्क बढ़ जाता है.
Okay.
और खास तौर से if people are also taking alcohol along with smoking or these products, then the risk of esophageal cancer goes up much fold higher. Apart from that, जो लोग सुपारी गुटखा वगैरह खाते हैं उनका रिस्क बढ़ जाता है. एंड इफ यू हैव एसिड पेप्टिक रिफ्लक्स, मतलब आपका एसिड रिफ्लक्स होके वापस स्टमक से फूड पाइप के अंदर जाता है, तो उन लोगों के अंदर भी इसोफेजियल कैंसर का रिस्क हाई होता है.
Okay.
So we see this very often even in village women who smoke hookah. So it is very common in those females, and if some females in villages they take BD also. So BD and hookah, that is a very very important risk factor for esophageal cancer.
Okay, so in terms of the screening or diagnosis that is available, what are the ways in which esophageal cancer could be detected?
Okay, so that's a very good question because to treat any cancer, I think the most important step is to diagnose it early. So, to diagnose any cancer, we must know what causes it and what are the warning symptoms. So, if, as I said, it's a food pipe cancer, so if anybody has any difficulty in swallowing food, मतलब आपका खाना अगर अटकने लग जाए, so that is the first symptom.
Okay.
मतलब आप अगर रोटी आराम से खा पाते थे और अब रोटी खाने के लिए आपको साथ में पानी की जरूरत पड़ती है, या फिर आपको खिचड़ी दलिया खाने में भी तकलीफ हो रही है. और कभी कभी पेशेंट्स हमारे पास ऐसे आते हैं जो अपना थूक भी खुद नहीं निकल पाते. So that's an advanced stage of esophageal cancer. So if you have any difficulty in swallowing food, and sometimes patients may just have symptoms of weight loss, not feeling like eating, they might have a feeling of acidity. So these are the main symptoms, but the most important symptom is difficulty in swallowing. So if the tumor has progressed and if we have not taken treatment during this time, then cancer may spread to surrounding structures.
Yeah.
Like if it spreads to the windpipe, which is known as trachea, patient may have coughing when they start eating food. जैसे ही रोटी खाने लगे तो खांसी उठने लगेगी उनको.
Okay.
If it spreads to the liver, they will have weight loss. They may not feel like eating. They may feel fatigued very easily. If it has spread to the bones, then they might have bony pains. If the cancer is spread to the lungs, then they may have difficulty in breathing. They may have chest pain. They may feel like tired on climbing few stairs. And if the cancer is spread to the brain, then they may have headache, nausea, vomiting,
Okay.
fits, or seizures. So in advanced cases, it may present like that.
Okay. Okay. And how difficult is it to diagnose this cancer? Because different cancers have a different level of difficulty of diagnosis depending on the location and the disruption to their day-to-day life. So, out of all the patients, how many patients come at a late stage and how many come at an early stage?
So the problem with esophageal cancer is it's not a very good cancer. I would say it's not a very good cancer, and the main reason for this is that because it is diagnosed late. And why it is diagnosed late, I would say because we have a very low index of suspicion. Patient keeps on waiting till they have difficulty in swallowing their own spit. So
Okay.
we should not wait that. So what happens is that sometimes when patients have difficulty in swallowing, as I said, food pipe cancer can happen in the neck when it is known as in the cervical part of the neck. Then it is known as cervical esophagus. It
Mhm.
can be in the middle part of the food pipe when it is known as middle thoracic esophagus, and it can be in the part which just joins the stomach, which is the lower one third, or the tumor of the gastroesophageal junction. So
Okay.
sometimes what happens when patients have difficulty in swallowing, they go to the ENT specialist. He does an ENT examination, and tumor may not be sitting in the cervical part of the esophagus. The tumor might be in the middle part or the lower part of the esophagus. So, and endoscopy is not done at that time.
Yeah.
So patients just get a symptomatic treatment, and as I said, it's not a very good cancer. So unfortunately, at times it is diagnosed late. So if we do endoscopic on time, on when we have initial symptoms, then it can be detected early. So sometimes patients come to us. We tell them to get an endoscopy done, but they are not willing to get it done because it's slightly a painful procedure. So they keep on delaying their symptoms, and that is why it is diagnosed late. So if anybody has any problem in swallowing food, they should get a thorough head and neck examination as well as an endoscopy. They are the first steps to diagnose this cancer. And then we have to get a CT scan of the chest and abdomen both. Because, as I said, it can be in the neck part, cervical part, as well as the abdominal part of esophagus. And if the patient wants to get only, and it should be with a contrast, means with a dye which is injected in the vein. And if the patient does not want to get 2 3 CT scans, then a whole body PET CT scan with contrast is one step to diagnose esophageal cancer, where it can tell about the local extent of tumor. It can also tell about any lymph nodal spread of the tumor or any distant spread of the tumor in any bones, liver, or lungs.
Okay.
And we must not forget that whenever we are suspecting any cancer, the final confirmation is always done by a biopsy. एक छोटा सा टुकड़ा लिया जाता है, उसी से कैंसर का डायग्नोसिस होता है. So if we don't do a biopsy, we can never say with certainty that a patient is having cancer. And without a biopsy, we cannot treat any treatment.
Yeah.
So biopsy is a must, and it also tells what type of a carcinoma I am dealing with. Am I dealing with a squamous cell carcinoma, or am I dealing with an adenocarcinoma?
Mhm.
Moreover, we can do molecular markers on the biopsy, which tell us in deciding what particular treatment would be offered to the patient. So people are afraid that biopsy may lead to spread of cancer, and that is why they keep on delaying it. But let me tell you, no biopsy ever leads to a spread of cancer. So it is a safe procedure and a must to diagnose as well as treat any cancer.
Yeah.
So the important message that I want to give here is that please don't delay biopsy for fear of that it might lead to spread of cancer, and it's a one time procedure, and this is a vital test to diagnose any cancer, specifically for esophageal cancer as well.
Okay, great, ma'am. I think that was very comprehensive through the entire process of diagnosis. Now, let's move on to the treatment aspect. So, after the
Yeah.
diagnosis is done, what are the different modalities of treatments available for patients and how are they chosen?
Okay. So that's a very, so as I said, that every cancer has few stages.
Yeah.
So there's a stage 0, which is a pre-cancerous stage. If the tumor is detected in that stage, then it is very, very easy. The patients can be completely cured because it takes few years for a cancer to develop. So that is the precancerous stages when the cancer is not fully developed. So if we diagnose a cancer in the precancerous stage, then definitely patients will be curable. Okay. Then stage 1 is when the this tumor starts from the inside of the food pipe, and then it spreads to the outer lining. So if the tumor is in the innermost lining of the cancer of the esophagus, then it is a stage 1 cancer. If it is spread a little beyond, then it is a stage 2 cancer. If it has involved more than that thickness of the esophagus, it is stage 3. And if it is spread beyond the esophagus into the neighboring structures like lung, heart, then it is a stage 4 cancer. And if it is spread beyond that to other distant organs like liver, lungs, bone, then it is a stage 4 cancer. So, depending on the stage of the cancer as well as on the location of the tumor, a treatment is decided. What it means is that if the tumor is in the cervical part of the esophagus, means in the neck part of the esophagus, then no surgery is being done. And then the main modality of treatment is radiation plus weekly chemotherapy. So the main treatment for main modalities of treating esophageal cancers are radiation, which is a treatment which is done by high energy X-rays. Then surgery, which is the surgical removal of the part which is affected by the tumor. And third is chemotherapy or immunotherapy. Chemotherapy means either pills or injections which are given through the IV line to give the chemotherapeutic agents inside the body which kill the cancer cells. And immunotherapy are new agents which are treated to treat cancer. So if the tumor is in the cervical part of the esophagus, then no surgery is being done, and then we treat the patients with a combination of radiation and chemotherapy. If the tumor is in the middle part of the esophagus, then depending on whether it is an adenocarcinoma or it is a squamous cell carcinoma, but usually in most of the cases, we give, if it's an early case, then we usually do give combination pre-operative chemo radiation. Means surgery has to be attempted, but to do get better outcomes from surgery, we first give a combination of radiation and chemotherapy for say 1 month, give the patient 6 to 8 weeks gap for the tumor to regress, and then take the patient up for surgery.
Okay.
If it's a lower third part of the esophagus or the part which is adjoining the stomach area, then also pre-operative chemoradiation is an option. But some surgeons, they are not very comfortable with getting a radiation first. So in such cases, pre-operative chemotherapy may be done. So ideally, any patient with esophageal cancer who walks in your OPD has to be first jointly seen by a team of radiation oncologist, a medical oncologist, a surgical oncologist, a gastroenterologist, a radiologist, and a nuclear medicine specialist, and of course the supportive team, which includes your nursing staff, your nutritional expert, your physiotherapist. So after the decision is made in the multidisciplinary tumor board, then the treatment is should be started. For patients which have a very small tumor, say less than the 3 centimeter tumor, it's an early grade. There is no invasion of the tumor into the lymph vessels or into the venous invasion is there. Then these patients may just undergo an endoscopic resection. But
Okay.
unfortunately, very few patients come to us in such an early stage. Most of the patients who come to us have a tumor which is more than 5 centimeter, which is spread to the lymph nodes and to the adjoining areas. So, as I said, early detection is the key to diagnose a cancer, uh, improve the survival rates, and give a good quality of life of the patients. For patients who are not able to swallow, who have difficulty swallowing even their own spit, in those cases, we should first try to do something for the feeding for the patient, either by putting a tube in the small intestine, which is known as feeding jejunostomy, or we should first do something to maintain their nutrition. Mind you, so many patients come to us who get a stent placed, a metal stent placed inside their food pipe to relieve obstruction. I would strongly discourage that. It should be attempted only in those patients who have a very limited survival, say for 3 months. And so we have better modalities. Please, be, getting before getting a stent done, please talk to your doctor, because if a stent is placed, then the surgeon may not be able to do surgery. Radiation oncologist may find it difficult to give radiation, and a curable patient may be rendered incurable because of the placement of a wrong stent. So even these days, we get a many patients who have got a stent placed, and we find it difficult to do a curative resection for such patients.
So if you could just spend a minute on the stent problem that you raised, is it a part? I don't believe it is part of treatment of cancer. It is more of a symptomatic relief for the obstruction in the food pipe, right? So how does
Right.
that go about? Like, what specialty of doctors do they go to get this stent placed?
So stent is usually placed by a gastroenterologist.
Okay.
So basically the thing is, when they get an endoscopy done, endoscopy is done by a gastro specialist who at the same time takes a biopsy. So
Okay.
sometimes, uh, uh, because some doctors may not be very familiar with the advanced techniques which have happened in treatment of cancer, and they say for symptomatic relief and just to make the patient eat through the mouth, they put in a stent to temporarily relieve the stent, to temporarily relieve the dysphagia. But the problem is, uh, we are not able to give curative treatments to such patients. So, as I said before, also, stent should be considered only for those patients who have exhausted other modalities of treatment,
Okay.
who have a very limited survival, say for 3 months, and we don't have anything else to offer to such patients. So, it should be put only after consultation with a oncologist, not before any oncologist has seen the patient. A surgical or a radiation or a medical oncologist should see the patient, and there shouldn't be no hurry to put in a stent. This is a very, very important message that I want to give to most of my patients, as well as to my gastro specialist. The problem with the stent is that sometimes when you put in a stent, then when the tumor initially, when the tumor is there, then the stent is held in place by the tumor. But when you give radiation or chemotherapy, then at times the stent slips down, and then it is very, very difficult to retrieve the stent back, and in those cases surgery is not possible. So stent should be placed only after a long discussion with the treating team, and not just like that.
Okay. Okay. Fair. So now moving on to the next part is after the treatment modality, after the treatment has been decided, this how can the patients prepare themselves? Because like you said, most of them might have lost weight. Most of them already have difficulty eating. They might have fatigue as an issue even before treatment. So how do they physically and mentally prepare themselves for the treatment?
That's a very, very pertinent question, I must say, because in India, I think the most important deficiency in our system is that we don't give psychological support to the patients. So the diagnosis of a cancer starts with psychological support. And at the same time, I always say that rehabilitation of cancer patients does not start at the end of treatment, it starts at the time of diagnosis. So, as soon as a patient with esophageal cancer is diagnosed, we should counsel the patients. We should send the patient to a nutritional specialist or a dietitian who should make a diet chart, calculate the calories, how much the patient needs, and it should be this diet chart should be made in consultation with the patient and the family, because the choices of patient have to be taken into mind. Because if we don't counsel the patient or treat the patient about the importance of nutrition, they may just ignore it, and because they have less nutrition they get fatigued, and because they are tired they don't feel like eating, so it's a vicious cycle. Moreover, if the nutrition is lacking, they will not be able to complete the treatment on time. They may not be fit for surgery. As I said, pre-operative chemoradiation is in a way a preparation for surgery. Okay, so the patients for whom it has been decided that surgery has to be done, in such cases the dose of radiation is different versus in those patients in whom it is decided that surgery is not possible. So in those cases we give a complete or definitive dose of radiation. So it has to be decided beforehand. So sometimes when we tell the patients that you have to undergo surgery, and after radiation, they get a good relief. And sometimes patients don't go for surgery, and because they run away from surgery. So again, the problem is then the patients come back to us when they are not curable.
Mhm.
So so that is why the decision has to be reinforced to the patient. What will be your treatment, whether it will be just surgery, whether it would be radiation plus chemotherapy only, or it has to be pre-operative chemoradiation followed by surgery. Certain patients who undergo surgery first, they might still need radiation and chemotherapy depending on what shows in the biopsy report.
Yeah.
So because the treatment is prolonged, nutritional has to be maintained. So as I said, if the patient is eating uh, solid diet, then you don't need to put in any feeding tube.
Mhm.
But if the patient is eating liquids in a fair amount, then also you don't need to put in a tube. But if they're not eating well, so either we can put in a Riles tube through the nose, if that is possible to insert, or there can be a peg tube insertion which is put through this and through endoscopy it is placed, or preferably we put a feeding jejunostomy, that is a small feeding type of tube is put in the small intestine. So the patients should be counseled about the role of high dose of nutrition. We should also counsel them about taking treatment for any coexisting comorbidities that they might be having. Means they should take their treatment for diabetes, cardiac problems, hypertension, asthma, and at the same time, breathing exercises should also be taught to the patient so that they have a good lung capacity, and they can undergo surgery safely. And even after surgery, the patients have to keep on doing all these exercises and take care of their nutrition. So counseling of the patient, early referral to a nutritional specialist, physiotherapist, occupational therapist, these are also very very important components of treatment apart from radiation, surgery, and chemotherapy.
Okay, perfect. Because this actually answers my next question as well. Because my next question was around, like you rightly said, psychological support and nutrition is a very critical element of preparing patients for surgery, uh, patients for treatment. On the contrary, there is also the element of, you said, some breathing exercises, some basic lifestyle changes to be able to be physically prepared for the treatment, right? And moving on to the next aspect, which is post treatment. What are the success rates? What is the disease free survival for patients who have undergone treatment?
So I think that's the crux of every treatment. Every patient who takes treatment wants to know, how long will I be able to live? What will be my quality of life after treatment?
Yeah.
Will I be able to marry off my daughter? Will I be able to see my grandchildren? So I think these are the questions in every patient's mind. So as I said, esophageal cancers are unfortunately not very good tumors. The only reason being they are diagnosed late. So
Mhm.
I must congratulate you for having this awareness session on esophageal cancer, because if patients, I think the step to cure is early diagnosis and prevention. So as I said, if the patients don't smoke, if they don't take alcohol, if they don't take any tobacco products, they maintain a healthy lifestyle, they don't take very spicy food, they take good nutrition, and they have a good mental status. I mean, they are in a good spirits to tolerate the treatment. So that such patients, they do definitely better than other patients. So it's not that leaving smoking is important only before you have started treatment or you are undergoing treatment. So the patients have to be always reinforced about the need for leaving smoking, quitting smoking absolutely, not taking to alcohol at all after the treatment is over, because if they keep on smoking or if they keep on taking alcohol, then the chances of disease recurrence are very very high, and the chances of disease coming back in lungs or in other parts, because smoking itself leads to cancer of 16 sites in the body. So if a patient has been smoking, they can develop, even if they might be cured of the food pipe cancer, they may develop cancer somewhere else, or they may throw metastasis anywhere else in the body. So the patients who are diagnosed early, say less than 3 centimeter tumor of course their survival is very, very good and they don't need a complete surgery. They may just do with endoscopic resections. But patients who have a large tumor and who have undergone a complete treatment, means radiation, chemotherapy, and surgery, they will do better as compared to patients who have underwent only radiation. So surgery, as I'm saying again, is a very, very important part of treatment for middle and lower third part of cancers, not needed for cervical or the cervical esophageal tumors. So if a patient has underwent a complete treatment, the chances of 5-year survival is very, very good, versus patients who are diagnosed in stage 4, when the chances of survival are only less than 10%. So only what it means is that if I treat 100 patients, only 10 patients or maybe less would survive for 5 years. So the chances of recurrence or disease coming back are maximum in the first 2 years of treatment. So means first 2 years are very, very critical for treatment. So even after the patients have completed their treatment, they should continue and getting their follow-ups done. They should go for regular checkups done. And if the tumor has not come back for 5 years, then the chances of cure are very, very good. So earlier, when I started my career, I would hardly see patients surviving for 6 months or 9 months. But now we have good survivors who are living beyond 5 years also. So I think early index of suspicion, awareness about cancer, early diagnosis, proper, complete, and timely treatment are the ones which are crucial factors to decide how long a patient is going to live, and whether they bring changes in their lifestyle, don't smoke, don't take alcohol, uh, avoid spicy food. So these are very, very important factors to prevent the disease coming back again.
Okay.
Yeah.
Okay. Perfect. I think that with that, I've completed all the questions that have been listed for this session. And lastly, would you like to share anything to the viewers? Some of them might be patients who are about to undergo treatment or currently undergoing treatment. So, do you have any message that you'd want to share with them?
Is it related to COVID or in general?
In general,
In
yeah,
general.
yeah.
Okay. So the first and foremost message that I want to every patient is that don't be afraid, even if you are diagnosed with cancer. Don't run away from the diagnosis. Don't hide your symptoms. Go to the right specialist. As I said, go to the right specialist is the most important thing. Means go to an oncologist. Okay. So, and as I said, most of the hospitals have tumor board meetings where they decide what is the right treatment for the patient. And always take along an intelligent attendant with you. Note down all your questions which you have before going for any consultation, because at times when the information is provided, it is too much of an information. We forget to ask what we want to discuss with the patient. Carry a notepad, note down whatever important relevant information is being provided to you, or you can ask the doctor to note down the relevant points, and have an intelligent attendant who can assimilate and comprehend all the information that is provided to the patient.
Okay.
And please don't delay the treatment, because the quality of life is very, very good if you take treatment on time. Now we have better diagnostic modalities, we have better treatment modalities, we have better rehabilitation modalities for the patients. And please don't ever be afraid of biopsy, because that delays, most of the diagnoses are delayed because of endoscopy and biopsy. So if you are afraid of endoscopy, then the doctor can give you a local anesthetic and do an endoscopy after that, so which will not be a painful procedure. So if you are properly diagnosed on time, properly staged, the biopsy is done, molecular markers are done. Say as I said, sometimes we do HER2/neu to do on the biopsy, and then we add trastuzumab or other therapies. For adenocarcinomas, we have now targeted agents like ramucirumab. And for advanced cases, even if you are diagnosed in stage 4, then we have multiple chemotherapy options, we have immunotherapy options also. So the technology is advanced, radiation modalities have advanced. Now we have IMRT, IGRT, with which we are able to save the lungs, heart, stomach, esophagus, critical structures from the side effects of radiation, so the long-term toxicities are very, very much lesser. And so that is why patients were earlier afraid of that radiation is a very, very toxic treatment, or chemotherapy is a very, very toxic treatment. It's not like that. We have very good anti-emetic agents to prevent nausea and vomiting. We have good agents to prevent infections which are happening because of chemotherapy. So it is better to discuss with a treating oncologist all the doubts that you have in your mind, and don't just sit at home because of hearsay, or because someone in your family was diagnosed with a cancer and usko ye hua tha, उसने ट्रीटमेंट कराया था तो उसकी वजह से ये हो गया, उसने बायोप्सी कराई थी उसकी वजह से कैंसर फैल गया। आपको जो भी डाउट्स हैं, आप प्लीज अपने डॉक्टर से समझिए। आप चाहे 2 ओपिनियंस लीजिए, 3 ओपिनियंस लीजिए, पर ट्रीटमेंट टाइम पे शुरू करिए। एंड वंस यू हैव डिसाइडेड दैट you want to take a treatment, then please stick to a particular doctor or a particular institute. Don't keep on jumping from one place to the other place, because it will unnecessarily delay your treatment. And in cancer, time, and the time when the treatment is started is a very, very crucial factor, because if you keep on taking multiple opinions, if you keep on delaying your treatment, then the cancer which was diagnosed in stage 2 might become stage 4, when it may not be curable. So have a good bent of mind, keep your positive thoughts, surround yourself with people who are positive. The people who give you just negative vibes, keep away from them. Don't stay away from toxic people. And if you are taking any alternative treatment, please let the doctor know, because they may have adverse effects and we may not know. So that it is. And if you are having any diabetes, hypertension, cardiac diseases, please let the doctor know about them also, so that the doctor can decide, because certain medicines we might have to modify treatments if you have any other comorbidities. So best is to have an open discussion with your treating oncologist. Don't hide anything. Discuss about the cost of treatment. They might be able to help you even in the cost. So start treatment on time. Adhere to the treatment which has been advised. Don't run away from surgery. Don't run away from chemotherapy. Don't run away from feeding tubes if they are needed. But stay away from stent if possible. Again, I would say.
Okay. Perfect, ma'am. Perfect. Thank you so much. I think with that, we've completed all the questions pertaining to this session. So I think you've been very articulate and very clear and comprehensive for each and every question that has been, put across. So I'm sure people who would be watching this will find
So
this.
one thing what I would just like to say, that this at this point of time, most of the doctors, they are doing teleconsultations. So
Okay.
if due to any reason you are not able to go and visit a doctor, then you can either have a phone consultation or a video consultation or a Skype consultation or
Yeah.
an online consultation also.
Yeah.
So if you are in doubt, you can opt for these options also. And but don't delay the treatment because of any of these factors.
True.
So start treatment on time. That's the most important message that I want to give again and again.
Okay.
And
Perfect.
even with cancer, life can still be very beautiful. It can be still be worth living. Fulfill your dreams, dance, paint, write that poetry book that you wanted to write. Even after your treatment, you can go for climbing, for mountain climbing, for you can go and visit different places. Have gratitude for the people who are with you in this journey, may it be your family, the health workers or the support staff, or anyone who helps you in any way. And have faith in God, because everything is can be win over cancer is the mantra, not being afraid of cancer is not the mantra. So if we have to live with cancer, still treatments are possible. A patient can still live with cancer with dignity and with a good quality of life. So cancer does not prevent you from enjoying life. Live it every day as it comes.
Perfect.
That's also I want to tell to the
That's the
patients.
most critical aspect of what we also try to do. Wonderful, ma'am. Thank you so much. And for all people who would be watching this video, I'm sure you'll find this information very useful and relevant. And if you have any questions, feel free to drop them in the comments, and we would be sure to get back to you. With that, we conclude this interview. Thank you so much for your time, ma'am. Thank you for joining us.
Thank you so much. Thanks for having me here.